The second, suspension of the disbelief. So we will not believe that this is not a patient, and we will not believe that this is not breathing, and we will believe that he has changeable vital and he is a patient for our learning and teaching purpose. Then the fourth component is the psychological safety. The participant, the candidate should feel psychological safe. They should not feel, ashamed, blamed, or humiliated when they are asking questions. They should be comfortable because the purpose of same exercise is to make mistakes and learn from those mistakes so that when you go to the clinical area, you don't repeat those mistakes. So please feel psychologically safe and then have some kind of mental visualization. So when you are doing, some procedure, we will learn in sim session, but when we go to clinical arena, we will mentally visualize those steps so that fewer mistakes are committed and procedure is performed smoothly. And then, of course, the take-home message. So these are the important points whenever we are having a sim session, we must keep in mind. And for me, the first and foremost is the psychological safety. One should not feel anything embarrassing while asking questions. We may think that this question is stupid, this question is wrong, but it is not. No question is wrong or stupid. One should go ahead and ask and clear his or her doubts. Okay. So now I will demonstrate our mannequin. So it has got some special features. So this is our mannequin for ICD and for needle decompression. So for ICD, can you see Dr. Asani? Asani, you can see the mannequin. Please unmute yourself, Asani. So this is the chest belt. Okay, this is having muscle layer, this is having blood vessels also, and this is the pleura. And you have to change after putting 4 chest tubes. And then we have lungs inside. This is what you feel when you do a finger sweep. So these are the important points we have incorporated. And this is our ventilator simulator. We have attached. This is the ventilator simulator I have designed, and this is causing inflation and deflation for lung. And this is a very important feature when we are putting chest tube. So these are the unique features we are having. And then after putting the chest tube, when you attach chest tube with the other water stream drainage, then you will have bubbling inside the water stream drainage, which I will demonstrate after some time. Okay. Now, Asri, can you unmute yourself so that we can talk? Yeah. So do we have resident here? Because I want to discuss what are the indication of the placing a chest tube. If somebody can volunteer, but if not, then I'll go ahead and discuss the indications and other things as well. So should I go ahead and discuss?
Actually, I have one of my residents, Dr. Muhammad Haji. He joined us. He's a senior resident general surgery. Maybe Muhammad can join us at least for the discussion. If you like, Muhammad.
Yeah, I am here, doctor. Thank you.
Good.
Okay. So whenever we have decided to put a chest tube, there is an indication that we have to take an informed consent. After that, we need to have all our preparation with us so that nothing is missing. So when we are putting chest tube, we need to have equipment and we should have underwater seat prepared and ready to be attached with the chest tube. Okay. Then various steps of the procedure. Then what are the various complications? What are the contraindications? So these are the 6 steps we should take into account when we are performing any procedure. Now, we will discuss the scenario of pneumothorax in this patient when I am demonstrating the skill. So the main indication for putting chest tube, either there is a air or there is a fluid in the pleural space. The fluid could be blood, it could be pus, it could be iris also. And these are the routine indication. But of course, there are other indications for after pneumorectomy or after esophageal surgery. they are elective indication for putting chest tube. But we are talking about putting chest tube in case of trauma, in case of pneumothorax, or in case of combined scenario. Okay, so so now I will demonstrate the skill. So first of all, we have to put the patient in a proper position. Patient can be in the sitting posture or it can be in supine posture. The arm should be abducted, and we must explain this procedure to the patient so that we can get this operation. So after explaining the procedure and attaching our pulse oximeter, maybe oxygen on flow, and we will decide the landmark. So I have given two landmarks. So this is our sternal angle. So I have given a sternal angle, and this is the second rib, and the place below the second rib is the second process place, and this is third. You can see the finger going down, so you can nicely feel. And this is four, nipple is there, and this is the fifth. So I have given four and the fifth. So you can see this is the intercostal space, the finger going inside, and this is the rib. So I will be going in the fifth intercostal space in the safety triangle. As we know, the safety triangle is bounded by, by the lateral border of the back major and the anterior border of the latissimus broadside, and the base is formed by the fifth rib, and the apex lies in the axilla. So we will attack the arm of the patient and give anesthesia. And that's the point where I'm going to give my incision is upper border of the lower rib for the obvious reason, because at the lower border of the rib lies the neurovascular vessel. So I am going in the fifth space, and the safety triangle just anterior to mid-axillary line. Okay, so we will give anesthesia, good amount of anesthesia, just upper border, and then of course we anesthetize skin, subchondral tissue, periosteum, and the parietal pleura as well, because parietal pleura is quite painful. So once we have given the anesthesia, and nowadays you can also give serratus anterior plane block also ultrasound guided for putting chest tube. That will give a longer anesthesia. So once we have decided, we'll go in the fifth intercostal space, and I would recommend approximately 1 inch long incision. So the upper border of the lower rib, approximately 1 inch incision. And then we will dissect and dilate just at the top of the rib, dissect and dilate slowly, and then you close the cavity, and then you do the pleura puncture. So I get for the give way period. So that means I have punctured the pleura, and now we will bring out the cavity in the open state so that we have a sufficient opening. And now once we have done that, we will do a finger sweep. And now we will see, because now we have pressed the ventilator, and now we will feel the inflation and deflation of the lung, which I am feeling. We'll show you through the core also. Now we take the chest tube. Usually nowadays it is 28 to 32. And the tip of the chest tube should act as a guide. It should not be in the hole, and the the prong should not go beyond the tube. So the tip of the tube should act as a guide. And now we know, like when I was doing the finger sweep, and then I can say that this much I can go safely. Okay, so initially we will go this much, insert the chest tube. Now I will remove the cavity and insert chest tube, and the length will depend like the last eye and for 2 to 3 centimeters beyond that. Okay, so now we have insert the chest tube, and now we will attach in the underwater swim drainage. And now you can see there is a public inside the underwater cicatrice. So that means we are in the right place. Because what happens sometimes in case of thick chest wall, can you appreciate bubbling, Ashiri?
Very clear, the bubbling. I can see the underwater. See.
Right. So these are the like the features, like the finger sweep, inflation and deflation of the lung, and the bubbling. So that we are sure that we are in the chest, in the right cavity, right space. Because what happens sometimes in case of thick chest wall, the tube sometimes get coiled up, and then it is not in the place, and you detect after 2 to 3 hours sometime. So we have given that feature that ensure that yes, the tube is inside the neural cavity, and of course the finger sweep, so that you can enlarge the optic, you can break the adhesions, you can dislodge the cord, and you can be sure that you are not going to damage the lungs when you are inserting the cavity. So these are the various unique features we have in our ICD mannequin, and now uh, talking about the complications. What could be the complication of this procedure? Of course, the injury to the surrounding structure, then introduction of the sepsis, bleeding, but our concern remains with that trocar chest tube. If one is using that trocar chest tube, it is quite dangerous sometimes, and usually it is not recommended. But that can cause a lot of organ injury. It can puncture the lungs, it can puncture the heart also, esophagus, and you can puncture or damage the surrounding structure. Like on the left side, you can damage the spleen, you can damage the even stomach, colon also they have been reported. Or on the right side, you can damage the liver. So various complications yet you can read about, and my main thirst, my main emphasis is on showing the skill that if you perform ICD on our mannequin, that it becomes super easy to perform on the patient. Okay, now we will. Oh yeah, of course we can do suturing also. Okay, so you can we can have suturing also. So what kind of suturing you are doing, Asri? It's a pulse string or sweat or not? Can you unmute, Asri?
I did not hear you, but if you might allow me, can you just redemonstrate how to hold with the clamp? Because we need the camera really very close to, because this is the single most important thing for the residents also. The way you hold with the tip of the chest tube before insertion. If you can zoom on it. Yeah, just redemonstrate it, because I have seen them having difficulty with this one.
Okay, so the first thing is that you have to use a little bit large cavity. Okay, not the one with which you do the dissection and agitation. So this is like it should be never inside the hole, because when you are putting, so sometimes it gets entangled and it comes out when you are removing the cavity. Okay, so you have to hold like this. Can you see? So that the tip of the tube acts as a guide, not the calyx tip. So this is very important, and never inside the hole, never beyond the tube. The tube should act your guide, so that there are less chances damaging your mind. Is it okay now?
Very clear, very clear. Thank you. So we'll go ahead. We will pick up one of the residents just to. We have Dr. Muhammad Haji, we have Dr. Muhammad Al-Muhanna. Both of them, they can participate. We have Dr. Nargis also.
We will give them a scenario after this. We will give a last patient, we will give them a scenario. They will have to diagnose and read the x-rays, and then we'll see how they are going to perform, and maybe they can lead me for ICD insertion. We will do that for the resident. So, okay. So once we have done the finger sweep, right? So good dilatation. So now I am sure that this much I can go. Okay. So this much I can go inside. So keep your hand firmly and go this one. Now remove the cavity and now insert the tube. Now it depends whether you are going posteriorly or you are going towards the apex. Okay. So the last point is that now this is the last hole. Okay, last eyes. So usually I put 2 or 3 centimeters more inside so that there are no dimensions of emphysema. And then you connect to the underwater suture. And then you can do suture. So you can do suturing also. Is our good doctor Bilal. He has worked in Saudi Arabia.
He knows University in Health Sciences. There's research institute. So we can go for this or simply to be like that. You know, so there's those simple features that they-
So stitching is very important in chest tube because sometimes if you are not careful enough for stitching, then it will come out. It is very important that we must suture it properly and apply dynaplast to doubly secure it. So we are applying swatter knot. Ashiri, please unmute yourself so that we can talk. Dr. Muhammad.
Yes, sir. I can hear you very well. But you know, there are so many ways to shoot it.
Yes, yes. Which one you are following?
I can see that he did horizontal matrix stitch. They're fine for us. My own preference is Johannesburg knot, which is not very difficult to learn. But anyhow, whatever stitch to secure the chest tube will be fine for us. Ensure that during the insertion, the chest tube is out. Usually the my whole So I can see that he's doing Johannesburg now, actually.
Swato.
He's doing something like Johannesburg, which is actually Miller's knot. Yeah, it's Miller's knot. It's what's described by Miller, actually, from Stellenbosch, not from Johannesburg.
Okay. So,
But commonly known as Johannesburg. He's good.
After stitching,
Now he will secure.
we doubly secure. So we need so another way of securing chest tube. So even your stitch becomes loose, then also this will not come out. Tube will not come out. Apply some more.
One thing here during fixation, I think, Amar,
Yes.
we need to make sure that the line of pull will not be on the dressing itself. So in order to prevent accidental removal, despite having sutures and everything, you need to create like a mesentery over it. So what he's doing right now is excellent, because you don't want the line of pull to be directly from the chest tube to stitches.
So we'll show you
So
after dressing is over. Even if you pull the chest tube, it will not come out.
exactly, the stitches are very secure, but the way he's doing mesentery here, is trying to implicate it like a mesentery. So this kind of dressing also will protect further the chest tube.
So now, if you even if you put it, it will not come out. So this kind of, one upper, one lower side, and upper, it is very secure. Okay. So what else you want to do?
We discussed the complications, something the removal.
Yes, the one important point I would like to ask your resident, once we have put the chest tube, and now what we want to remove it. So when do you remove the chest tube? In which part of respiration, which phase of respiration? So if anybody can answer me that, because there is some confusion also about this. So they say like the full inspiration or at the end of the expiration. So they say that at the end of the expiration, there are less chances of, recurring pneumothorax. So it is recommended that you should remove chest tube at the end of the expiration, right? Okay.
Then the indications.
Once the whatever indication we have put in, like the lung has already expanded, we have seen the chest X-ray, okay, and the fluid which was there, rating less than 50 ml or 100 ml sometime, so you tend to remove. Okay.
Usually after 24 hours, we can.
It may take 2 days, 4 days, 5 days. Okay. Now we have scenario.
For this classic question, we know that there is no proper answer, but more physiological is actually expiration. But if you think about it, if you ask the patient to do Valsalva maneuver or arrest his breathing for whatever technique you're doing for him, he will not enter in atmospheric air. So the whole idea is to prevent atmospheric air from getting in. So it's more of, I know it's an academic question because most of the time you can't really do it at the end of expiration.
Okay.
That is open for discussion later on.
Right.
But I believe if you only arrest his breathing for a while, distract him or to do Valsalva, that's all needed to prevent entrainment of atmospheric air.
Okay, now in the same manikin, we have, electrically created tension pneumothorax, and you can decompress, tension pneumothorax in the same manikin on the right side. Camera.
Yeah, you can show the camera here.
So we'll show that needed decompression in the molar patient. But this manikin is having two scales. Just show the needed decompression. So you switch on this button, it electrically created tension pneumothorax. And then as usual, 4th or 5th intercostal space, just you will count with the sternal angle. And you can hear the hissing sound as well. Please unmute yourself, Asami. You can see the air, and when we remove the syringe, so there is a hissing sound you can hear. So basically, this is electrically created tension pneumothorax you have. So this manikin is having two skills, needle decompression and the ICD. Okay. Now we will have a scenario for your resident. Are they ready to participate and diagnose the problem Murad is having? Asmidi?
Yes, ya Shabab, Muhammad or Muhammad, if you are ready, or otherwise, Dr. Ibrahim Al-Balawi, I can see Muhammad S, Dr. Nargis, any one of you will be ready.
Okay.
You can participate.
So we are bringing the Murad patient. So we will just take the Murad patient.
Are we ready?
So now this is a scenario. This is a young man, unhelmeted. So this is a unhelmeted biker hit by truck. Develop Albert sensorium. Now he has come to our ED department. So as you can, I think here, can you hear the sound? He's snoring. Can you hear the sound? He's snoring. He's in Albert sensorium. And to the resident who is going to answer this question, so these are his vitals. So he's in Albert sensorium. Heart rate is 190 per minute. The saturation is 80%. BP is 80 by 50. And his respiratory rate is 34%. And if you observe his chest, then I think you can tell me, Mohammed, what do you see on the chest?
Right hemithorax is not elevated with the respiration.
That's not really. Okay. So that right chest is not moving, but okay, that is one thing. So first we will do the
Also, he is snoring. We are suspecting foreign body obstruction or any airway obstruction in
okay.
general.
What we should do now for him for this snoring, we'll do it jaw thrust. So just show the jaw thrust. So now we have done jaw thrust, and now this, I think you can hear that his breathing has become clear. Can you hear that?
So is he speaking now or what?
Yeah, he's groaning. So now the movement on the right side is restricted. They are distended neck vein. So what comes to your mind? And his breath sounds are diminished on the right side. When you auscultate, his breath sounds are diminished on the right side. It is restricted on the right side, and there are, distended jugular vein, and his saturation is 80%. In a patient of trauma, what comes to your mind?
So probably he has increased intrathoracic pressure.
He has got what?
Increased intrathoracic pressure.
Increase tension demo. Okay, right. So what will you do next? Once you think, because you have to have a high index of suspicion, so you think in terms of tension pneumothorax, what will you do? If you have focus,
We can auscultate and percuss. If
yes,
auscultation absent air sound and percussion there is hyperresonance, we will
yes. So
we
there
will have a high clinical suspicion of tension pneumothorax. Since we are in hospital facility, not in the street, we will go directly to chest tube insertion if available.
and there chest injury mark. So if we do compression, then he's groaning. So there is the underlying probably rib fracture. Okay. So we are thinking in terms of either pneumothorax or hemothorax. And once you do a focus, and once you do focus, and this is what you see on the screen. Can you see the screen? Can you see something on the screen? Yeah, there is no lung sliding sign. Okay, so that will tell us that he is having a pneumothorax. And of course, when we don't have a ultrasound, we can have a X-ray. So if this is the X-ray, screen कैसा हुआ? So there will be X-ray on your screen. What do you see on the X-ray?
jet black. Jet black appearance of right hemithorax. Right hemithorax.
So they, like on ultrasound, there is a absent standing side, or on X-ray, there is a remote side to the right side. So what is the next step you are going to do? Jawab. Going to- So what will you do for him immediately? So what will you do? Treatment by how will you
Insert,
treat him?
decompress, insert chest tube.
Decompression,
Yeah, chest tube decompression.
needle
Chest tube,
decompression,
not
and
needle.
chest tube. Okay. So we will do needle decompression in this patient. So again, both in precaution space. There is air coming out. So what will happen after we have done the needle decompression? The right side will also move.
Amar, I'm looking at the chat group. Most of the participants, rightly, I think, going for finger depression, right? Because the patient will end up with chest tube anyhow.
Yes,
So we
yes.
used to say, yeah, finger than plastic. We call it finger than plastic. Even if you omit needle decompression, you can start to lay, put your finger, decompress, and then replace your finger with a plastic when it's ready. So I want to hear from Doha here in the chat. Apparently very active in the chat group. We like to hear from you, Doha.
My point was, when you do needle decompression, then both now right chest is also rising. That's what I'm trying to show, like to the notice, not the experience one. Now you can see the right side is also rising now. So we have decompression. Of course, we cannot perform ICD in this mannequin. We can do only needle compression, and we can perform ICD on the other mannequin. But my point is here to the teaching point is, like once you do a needle decompression, then there is a rise of the chest on the right side also. That was our teaching point. Okay. So can you notice there is a now rise on the chest on the right side also?
Yeah, there is good rise now, bilateral. Dr. Haji, Muhammad Haji.
Yes, doctor.
So now
There is good chest rise.
we will put the chest tube and dispose the patient. Now we will.
How about saturation? Improved saturation? It was in the 80s.
Yes, this blood pressure now the change vitals. We will change the vitals. Blood pressure has come up to 100/70, and his saturation has come to 92%. Respiratory has decreased to 30 per minute. So we will change the change in vitals in the monitor. Now we will discuss two X-rays. This is for your resident. This was a patient of pneumothorax. Chest tube has been put, but the right lung has not expanded. And what else you can see on this X-ray? And what is the likely reason? Like there is no tube blockage, colon is moving, but after 4 days, the lung on the right side has not expanded. And there is a subcutaneous emphysema on the right side. Yes, that's the X-ray. What do you see there? You can reply in the chat. I want your comment on this X-ray. Okay. Yes. Yes, very right. So what could be the possible reason for this? He has been having chest tube for the last 4 days. He's still having subcutaneous emphysema. He's still having collapsed lung and tube is patent. So basically, I want to tell you that this patient had a cerebrovascular injury. That is why, no, there's no, this patient was having cerebrovascular injury. That is why his right lung was not expanding and he was having continuous subcutaneous emphysema on the right side. So whenever the lung is not, expanding and everything else is normal, then you must suspect cerebrovascular injury. That was my point of showing this X-ray. Okay? No, there's emphysema on the right side only. Okay. Now, this is another X-ray we had. So this is a patient of trauma who on examination showed respiratory rate of 34%, saturation of 80%, but there was something else on the left side. So can you comment upon on the right side, on the left side, sorry, whether he needs a chest tube or not? What is there?
No, this patient has diaphragmatic injury, so probably bowel.
Yeah, it could be bowel. So how will you confirm that? There were gurgling sound on the chest. So sometimes,
Auscultate.
yes, auscultate, or you can do a focus. So sometimes it is not always that you see a, black shadow or things in terms of pneumothorax. Sometimes there is a diaphragmatic injury, and this is the colon which has both inside the left chest of the patient. Very nice, very good, excellent. Okay. Now, this is another one. So this is a patient of stab injury, and we have a hole causing pneumothorax. So can we put chest tube through this hole? Now
No,
is
this
a
is
hole.
open pneumothorax. Open pneumothorax. We need to put a plaster with 3-wall closure, adhesive tape.
No, actually.
So we make it as a one-way valve.
No. Open pneumothorax has a definition. It is not an open pneumothorax. It's just a stab wound. So stab wound, there is an opening. Can you put the chest tube inside this hole or not? I'm asking you. But this is not open. There is a definition for the open pneumothorax regarding tracheal size. So would you put the chest tube through this hole or not?
No, we don't know where is the trajectory of this wound.
Okay, you don't know where the wound is going inside. That's what you are saying?
Create a new wound, no.
Create, okay, new site. Okay, why not this one? Now there is a ready-made opening. We can just push the chest tube. Okay. What else? Because we don't know where exactly this injury is going inside, right? So if we put the chest tube, we don't know where it will land. And secondly, of course, the chances of sepsis are much more when you put through the open wound, right? So we should never put chest tube in a opening, and we must use another space. Okay. All right. Yes, digestive the wound. That's very nice. Yes, that's the important point. Dirty wound. Absolutely. They are all intelligent resident of ICD. Now, I think this one, remember, ICD remember, somebody has put this chest tube in Saudi. Okay, you can see on the screen. So, what is the problem with this chest tube? Is it rightly placed, or there's something wrong with the chest tube? Would you change it, or you just think it's okay? It's okay. No need to change, and it is rightly placed. Too anterior. Okay. So what is the danger if it is too anterior? Let it be anterior. We were putting earlier in the second intercostal space also with lateral line. So what is your concern here? Heart injury, car injury. What else? Which is likely to be more common? More common, which you can injure. See, you can injure left internal memory artery. Okay. Aorta will come lower down, but definitely left internal memory artery you are likely to damage. Okay.
Can
And
I, Ammar, can I comment on this one since you posted?
that is
This is
going
not
to
from
the
my
side.
hospital, actually. Yeah. But just just to complete the picture, the one who put this chest drain is supposed to be one of the most senior consultants in a big academic hospital in the capital city.
That's
And
why I brought this picture.
just tell you that sometimes if you don't follow the principle, even big surgeons, they can allow this mistake. Now, I'm not sure he's or she's the one, but probably done by the resident, but without any supervision. We end up with this funny chest view. So we are here just to learn from the pitfalls of others.
Okay, right. That's right. Yeah, like as you said, it is a common procedure, but we need to master this particular procedure because it's required more often than any other procedure. Okay. So I think with this, is there anything else somebody want to experience? Share their experience, real life experience, any problem while putting chest tube, any story, any pearls for me, any take home message for me? How can we make better managing your feedback? So any comments from the participant or expert comment from ACV? Is our dear trauma surgeon, very busy, intelligent, creative, ready to teach, absolutely wonderful person. My future friend, I have not met him personally. A fantastic person. So anything you want to add, Asiri, to our simulation? Yeah. Pain nowadays, like people are putting chest tube in serrated central plane block, and that gives a wide area of anesthesia and longer duration also, right? Yes, definitely. When I am saying skin circular tissue, muscle is included because I am going up to the thoracic pleura. So muscle, you are right, muscle is included. You are very right. Asri, we are waiting for your comments.
I'm sorry, I missed that one because I was in another call. You were talking about,
We are talking about any pearls of wisdom from you, anything we can make better in simulation, and
yes.
your personal
Actually,
experience.
exactly. I think the best thing is to break it to micro skills, the way you did it.
Right. Okay.
You break down the skill to micro skills.
Right.
And then everybody should practice the micro skill one separate time. Yani, this I found what is most difficult for me, for example, or most confusing is this step. So I practice more as micro skill, and then I go and do it together and the sequence. And as you mentioned rightly, you should think of contraindication, respect anatomy, use the safe triangle, because I have seen people putting it very low. The chest strain was very low, hitting the diaphragm, getting the stomach sometime, which was very bad in peripheral hospitals, of course. If we could unify the way we manage chest tube and you break it to steps, and we do it in a uniform way, safe way, I think this is the purpose of this simulation, because such an important, essential procedure. However, we find even senior resident in our institution, sometimes they are confused about one part or another of the procedure. But I think we touch most of the. Sometimes you have a patient with large bulla, for example.
Right.
And so they need to look carefully before saying it's a pneumothorax. Sometimes it's a bulla rather than pneumothorax. That's it.
So this is regarding micro skill. I said in the beginning, mental visualization. So if you mentally visualize, so they are like doing micro steps only. So we need to do deliberate practices, and definitely micro skill is definitely, and then aggregating all the steps to perform the procedure. Definitely, that is definitely desirable.
Another point which I think is a barrier also, speaking of mental barrier also, in my country, most of the chest tubes are inserted by thoracic surgeons. Now, I'm not saying that they are everywhere, mashallah, but at 3 a.m. in the morning, sometimes you are alone in ER, or you're the only surgical resident or emergency resident. You need to put the chest tube by yourself. So when you need to do this one later on after practice, you will not find thoracic surgeon nearby. So we are trying to assure every non-chest surgeon in my country that yes, you can put chest drain. It takes us time and effort, reassurance, trying to explain that this is just chest drain. We don't call it chest tube, we call it chest drain. It's just another drain. You put it in the chest, in the pleural cavity. Now, as long as they put it safely and they avoid trocar,
yes,
they should not use trocar at all, unless they do it the modified trocar way, like just pull a little bit after establishing already the opening in the hole and putting what you demonstrated very nicely, the finger sweep. Finger sweep is missed by almost every Saudi resident I have instructed. They don't like it. I will force them to do it most of the time. They just do it just to please me. But believe me, if nowadays we see the adhesions even younger age, and I'm sure in India the same issue. Some of our patients, they do have some adhesion. So it's very risky to put any chest drain.
Yesterday only I was listening to lecture by the chairman of very big, and he was in All India Institute of Medical Sciences, and he is against doing finger sweep. And somebody asking why. Then his reasoning was, one, it is painful, and secondly, when you have air or you have fluid, then lung is far away. But somebody should tell him, as you puncture the pleura, the lung is going to expand and hit the cavity. So finger sweep is definitely a step without which we should not attempt insertion. That's definitely I mean,
Even in pre-hospital care, if you happen to go with the HIMS, if you decompress somebody and you keep fingering him, we call it like finger thoracostomy.
yes.
Make sure that the lungs are up. So when in our checklist, before taking the patient, we make sure that lungs are up. So mean to say there is no pneumothorax, pneumothorax. You just put your finger, do the sweep, touch the lung. Try to touch the lung to make sure that the lungs are up. So
But
lungs are
on
up,
either side,
touching lung.
finger. So when regarding
Mhm.
one person on either side. So finger thoracostomy. Okay. And when even chest tube are not available, you can do finger thoracostomy. Sometime. But you should not postpone it that chest tube is not available. You can do finger also.
I have inserted funny things. Anything, any tube structure you can literally put there. And the underwater seal, you can create in LMIC or remote areas or austere environment. You can have a simple bottle, and just put water and just dip it in. The whole idea is to get the water underwater seal. They get the tube down to some water seal.
One for the air, second column, and it will be just drain. Absolutely.
Yeah, in Africa, actually in Africa, you don't find, remote areas, you don't find the proper chest drain the underwater seal. So you need to improvise. And I think it's very important. One more thing also, the surgical emphysema by itself is not an indication of chest tube. We know that it might not be pneumothorax, but it can tell you that there is a pneumothorax. So I find also some practice, old practice, they keep cutting the patient, several cuts just to relieve the subcutaneous emphysema, which is not helpful. Because you need, if there is any pathology, it's in the pleural space and it's compressing the lung. So some people panic when they see the surgical emphysema and they start doing this stuff. They should really focus on what really killed the patient. They should put the finger all the way until they sweep in between the ribs up and down and feel the lung if they can. It will expand. Most of the time they will see immediate re-expansion.
So I have a question here. But if you have surgical emphysema serious enough to go to your neck, causing voice changing, maybe drooping of the lid. So do you sometimes put a second chest tube also? If it is affecting your voice and your
Occasionally we put, but I tell you, most of the air leak, if significant, it will be improved with one chest drain. Yeah. And if you need later on, you can put under suction, low motor suction. You can put under -20 or something.
Right.
But the real thing is that you should really decompress, make sure that you deal with the air leak, and deal with other cause of respiratory failure. Okay.
Right.
So
And
as I'm talking to you, I'm running some lifeline. Yeah. And
of course, you need mannequin for deliberate practices. You are monitoring that. You need our mannequin for deliberate practices.
I'm sorry?
You need our mannequin for deliberate practices, for teaching, chest tube.
Well, absolutely. I can find it very high fidelity, and really I like the way the mannequin is helping us to do deliberate practice, and it's within the capacity of any real trauma center to train using your mannequin. I think it's a marvelous way of teaching and training. As you know, we link performance to training.
Yes. So first of all, like if you are working in emergency, the first requirement is a solid training base, and that can come through deliberate practice and seeing various patterns. So that is definitely there. A solid training base is required when you are working in emergency department. It's very pattern. Absolutely. just regarding removal of the chest then, if the patient is still intubated, just to explore the removal. No, when patient is intubated, never remove the chest drain, never, ever. That is not recommended. Patient is intubated or positive pressure ventilation, so don't remove chest tube. Only when he has been extubated, he on spontaneous breathing, then you can, like according to clinical, parameter, his hemodynamic status, his physiology, you can remove the drain, but not on ventilation for obvious reasons. Nowadays, they are using treatment for pneumothorax. So, any final word so that we can close the session? For any sort of wisdom from Asari? Any questions?
No, sir.
So then we close the session, and I thank all you gentlemen for your time and spending your valuable time. It was nice interacting with you, and hopefully we will meet again, maybe with a surgical report. And bye bye.